you too. Welcome to Dr. Vibes, a learning point. Let us study this management of hypovolemic shock. You can divide this into three categories. First is the primary survey because shock is an emergency. Then you have to go for identification and quantification that how much blood volume loss has occurred. And lastly, the treatment of hypovolemic shock. So in primary survey, as in any case of emergency, you have A, B, C, D, E. Here you also add one small c. What does C stand for? Control of exsanguination. Then A is for airway, B is for breathing, C is for circulation, D for disability, E for exposure. Now, how will you secure the airway? You have to see whether the position of the airway is in correct place and you have to clean it from all the secretions. B, that is breathing. Assessment of breathing is done by checking the bilateral air entries proper or not. And you have to give moist supplemental oxygen to assure proper breathing. And you can also give positive pressure ventilation if required. For circulatory assessment, that is C, you have to check for the pulse rate, the blood pressure, and you have to give IV fluids. Here C also stands for cervical spine assessment. Oh yes, one more thing. You have to give IV fluids and that is given by 2 wide bore IV cannula. Right. Another C, as I told you, it stands for cervical spine assessment. And then you need to stabilize it. Finally, D is the disability that you can check by Glasgow Coma Scale, and one more scoring system is there. You just need to know that name. That is AVPU scoring system. Lastly, E stands for exposure and controlled environment. Next, you go to identification, quantification. That means you have to quantify how much blood loss has occurred. This can be done in an accurate way and this can be done in an inaccurate way. Now, accurate way involves the amount of blood in the pleura and the peritoneum. So this is an accurate way because here you can see how much blood is there and you can quantify it. There are some inaccurate ways as well. So basically, after surgery or during surgery, there is blood loss. So the inaccurate way of measuring the blood loss is by soaking the mops and the gauges in that blood and then quantifying how much blood is lost. One mop, when fully absorbed with blood, equivalents to 500 ml of blood loss. Now you also need to know what is the difference between a mop and a gauge. Several gauges stitched together and attached to a string is called as a mop. Now why is string placed? Because in earlier days it was seen that if a string is not placed, then the surgeons while performing the surgery left the gauge in the cavity of the operating patient. So this can lead to complications later on. Hence a string is attached to ensure that the string along with the mop has been taken out after the surgery is over. Another way of calculating the inaccurate way of the blood loss is by calculating the hematocrit. We know in stage 3 of shock, hematocrit decreases. So if hematocrit becomes less than 25, that means there is 1 liter of blood loss. And if the hematocrit becomes less than 20, it implies there is 2 liters of blood loss. There are some non-evident methods of blood loss as well. Suppose there has been clavicle injury. That implies there is 100 ml of blood loss. One rib injury, 500 ml of blood loss. If there is a fracture or injury to the humerus, that implies 750 ml of blood loss. And if the shaft of the femur is injured, then that is 1.5 liter of blood loss. And finally, pelvis injury leads to 2.5 liter of blood loss. Now that we are done with the accurate and the inaccurate methods of blood loss estimation, there is one experimental method as well. So basically, you take heavy water, that is water in which hydrogen is attached with a isotope, that is hydrogen labeled with the isotope. So that also helps you to estimate the amount of blood loss. Now one more thing is there, which is called as Rein's factor, which tells us about the formula of blood loss, which is equal to the weight of the blood that is soaked in mop minus the dry mop into 1.5 whole divided by 2. This is in case of a large mop. So that will give you the amount of blood loss that has occurred. Now, we are done with primary survey, we are done with identification and quantification of the blood loss. Now come to the treatment. So after you have identified the source of hemorrhage, you have to initiate the damage control resuscitation, that is DCR. Now what is the principle of DCR? The principle states that the dearranged parameters of shock should not be corrected when there is ongoing hemorrhage. So first, the deranged parameters like the vitals should be stabilized only after the hemorrhage is corrected. So DCR states that first of all, prioritize your coagulation or hemostasis, and secondly, the end organ perfusion is the target. Now, how will you control the how will you ensure hemostasis, or how will you prioritize coagulation? For that, you have to control the blood loss. You can do this by packing, you can do this by applying pressure, you can do this by waiting patiently. Now, this pressure can be a manual pressure when less than 3 mm pressure is applied, and 3 to 5 mm is by coagulation, and if you want 5 to 10 mm pressure, that is done by ligation, and up to 7 mm, that is ligature. 5 to 10 mm is ligation, up to 7 mm is ligature, and if you want more than 10 mm, then you have to use a stapler. So we are done with packing, we are done with applying pressure, and we are done with waiting patiently. This should control our blood loss. This should help us to acquire hemostasis and prioritize coagulation. We can also use some surgical methods like endoscopic control and angioembolization to control the blood loss. Now, let us move to the supportive treatment. That is, you have to stabilize the vitals now because hemorrhage has been controlled. So first you have to do the volume replacement, as we have discussed in the previous videos. If it is stage 1 and stage 2 of shock, just giving crystalloids will work. And in stage 3, you have to give both crystalloids and colloids. So basically 250 to 500 ml of fluid is given to a hypovolemic patient in bolus for 10 to 15 minutes. And after that, if there is sustained improvement in the blood pressure, then that patient is called as a responder. If there is transient improvement, but that improvement is not sustained, you call it as a transient responder. And if there is no improvement in the vitals at all, even after giving 250 to 500 ml of bolus, then that person is called as a non-responder. Our further treatment will depend whether the patient is a responder, transient responder, or a non-responder. In case of transient responder and non-responder, suspicious of ongoing blood loss is strong, and that requires urgent intervention. So now you have to go for oxygen delivery as a second one. First, you have to stabilize the vitals by giving volume of blood. Then oxygen delivery is by oxygen inhalation, by nasal prongs or nasal mask. Then we move on to organ support. If the patient is not responding well only to fluid resuscitation, then you have to give certain drugs like noradrenaline, dopamine, dobutamine, and adrenaline. This is all about the treatment. At first, you have to prioritize the coagulation and hemostasis, and second, you have to move for supportive treatment.